The second conversation, how to talk with a patient who has a POLST. In this video, we reveal how conversations differ based on the patient's recollection of previously documented end-of-life choices and advancing illness. We discuss how to have a follow-up conversation after a patient has already filled out a living will or had a POLST completed. The goal of the conversation is to utilize a patient's previously established decisions as a starting point for a conversation, while allowing the patient to add new information about whether their thinking has changed. The video demonstrates various scenarios to help assure patient preferences are clear, treatment is aligned with preferences, and can be appropriately defined in the medical record. The physician assesses the patient's understanding of the prior conversation, updates him regarding his health status, and confirms these are still his values. After clarifying the patient values, the physician makes a recommendation about what should be done and what should not be done. In the following clip, the patient is in stable condition and remembers his previous POLST discussion. Notice how the physician prompts the patient to explain what he remembers.
So, Mr. Donaldson, I did want to touch base with you about one other thing. Do you remember the last time you were in the hospital, you talked to the doctors about your views if you should get a lot sicker, and you may have talked about machines and CPR and all that stuff?
Yes.
Okay, what did you tell them?
I told them I did not want CPR and I didn't want any machines.
Okay, is that still what you're thinking?
Yes.
Okay, so I'm going to make sure that the doctors know that. We're going to put in an order in the chart, so if something horrible, if something should happen, and I'm hoping it doesn't, they're not going to put you on breathing machines, they're not going to do CPR.
That's what I want.
Okay, and we're going to continue the antibiotics, though, and hope that this gets better. Okay.
Note how the provider asked open-ended questions, explored the patient's previous understanding, discussed previous conversation, and asked what the patient remembered about his previous code status. In the following clip, the patient is clinically stable. This is the second POLST conversation, and the patient does not remember his previous choices. Notice how the physician asks the patient if he remembers his previous conversation.
So, Mr. Donaldson, there was one other thing I want to talk to you a little about. Do you remember the last time you were in the hospital, you talked to the doctors about breathing machines and if your heart stopped, what you thought about CPR and those kinds of things?
No, I don't remember saying that.
Okay. Okay, what they wrote a note that they had talked to you about all that, and what the note said was that you were pretty clear that if something should happen and your heart should stop, that you're like, oh, I don't want to be on those machines, that if my breathing gets that bad, it sounds like you've been on a ventilator before, you're like, oh, I don't want that. Has anything changed?
No, that's still what I would want.
Okay, so what I'm going to do is I'm going to make sure that all the doctors know that. And we're not going to do those things. We're going to hope that the antibiotics work and you get better and get out of here in a couple of days.
Thank you.
Note how the provider reminds the patient of the previous conversation and then confirms these values, summarizes previous conversation and builds upon it, asks if anything has changed, and makes a recommendation based on the conversation. In the following clip, the patient is clinically unstable and remembers his previous POLST discussion. Notice how the provider discusses the implications of the patient's values for the current plan.
So, Mr. Donaldson, I wanted to talk to you a little bit because your breathing is a lot worse since you've been here. Do you remember talking to your doctors the last time you were in the hospital about what you were thinking if you should get a lot sicker?
I do.
Tell me what you said.
I told them that I did not want to be resuscitated, and I didn't want CPR.
Okay, and I just wanted to check to make sure that that's still what you're thinking.
I'm very tired.
Yeah.
I am.
Okay. I think it's a completely reasonable decision. Okay?
Thank you.
What I'd like to do is give you some medicine to try to help with your shortness of breath. It may make you sleepy, And I'm a little worried that we may be getting close to the time where your breathing is so bad that you might not get through. Yeah. I want to make sure that I call your family and make sure that they know. I know your son's on his way in. I want him to have a chance to talk to you on the phone if he wants to talk to you.
Please.
Okay.
Note how the provider imparted knowledge about the condition using simple language, established patient's understanding of choices, validated patient's choices, communicated how patient's symptoms would be managed, and suggested a plan for future treatment. In the following clip, the patient is clinically unstable and does not remember his previous POLST discussion. Notice how the provider reminds the patient of what was said and asks if that is still what he is thinking.
So, Mr. Donaldson, I think you've gotten a fair amount sicker over the last 24 hours. And I did want to touch base with you. Do you remember the last time you were in the hospital? You talked to the doctor about machines and about CPR and all that stuff?
No.
The doctor talked to you about it last time, and he wrote a really long note in the chart. Can I tell you what she said?
Sure.
She had said that when she talked to you that you were like, oh my goodness, if I need to be on a breathing machine, that I've gone through that once and I don't want to do that again. If it's my time, I just want to be kept comfortable and die naturally.
I said that?
Mm-hmm.
That sounds like me.
Has anything changed since then?
No.
I worry that we're at the time that we would have to make those decisions. And so if things are the same, I think we should begin to focus on keeping you comfortable, because I'm worried that your breathing is so bad that your time might be very limited.
That sounds like a plan.
Okay. So I'm going to make sure that I know that we talked to your son when you were in the emergency room, but I'm going to make sure that he gets here. Are there any religious traditions that would be really important?
My son will know.
Okay, so I'm going to also give you a little dose of opiates that may make you sleepier, because I want to try to make your breathing more comfortable. A medicine like morphine.
Okay.
Okay?
Note how the provider built upon previous discussion, asked permission to give information, asked if anything has changed, and delivered information in a sensitive, straightforward manner, avoiding technical language and euphemisms. In the following clip, the patient is clinically unstable and does not agree with his previous POLST decision. Notice how the provider probes for more information and starts a new goals of care conversation.
Okay. So, Mr. Donaldson, I did want to talk to you about one other thing. The last time you were in the hospital, do you remember talking to the doctors about what you'd want if you got a lot sicker? They may have talked to you about CPR or breathing machines or that kind of stuff?
No.
Okay. Can I tell you what they said? They talked to you and they wrote a note. Can I tell you what they said?
Yes.
They said that you were pretty clear that if you should get so sick that you couldn't breathe on your own, that you didn't want to be on breathing machines, and that if your heart should stop, you're like, ooh, let me go naturally. Don't do that CPR.
No, I don't remember that.
Yeah. So does that sound like it's what you would think?
I just don't know.
Oh, tell me more what you're thinking.
I don't know what kind of quality of life I would have after. I don't know if I'll ever talk again if you put these things in me.
So let's step back for a second. What would be a quality of life that would be worth going through machines and stuff?
Note how the provider asked permission to give information, prompted patient to tell me more, and explored what matters with the open-ended questions. In the following clip, the patient is clinically unstable and the physician is discussing POLST with his daughter. Notice how the discussion with family differs from a discussion with a patient.
So I'm glad you came in. I don't know if anyone's talked to you about how your dad's doing.
No, not really. I mean, I know he was admitted, but I don't know anything.
He's gotten a lot sicker, and his breathing is much worse.
I'm sorry to interrupt you, but what do you mean by that he's gotten much sicker? And he's only just admitted for...
So he, despite us giving him as much oxygen as we can, he's not breathing very well on his own.
I'm sorry. All of a sudden?
Yeah, it's hard to it's hard to think that he came in the hospital getting antibiotics and he's gotten this much sicker this quicker.
Wow. Okay.
And because I can't really talk to him, I wanted to reach out to you because I think we need to make some decisions about what we're doing.
Okay.
I wonder if you had a chance, if you've ever had a chance, if you and he have ever talked about him getting really sick and what would be important to him.
No, I mean, we never wanted to talk about it, so...
Yeah, it's a hard topic.
Yeah.
He did talk to the doctors the last time he was in the hospital. He and Dr. Jones had a long conversation.
Mm-hmm.
Can I tell you what they said?
Yeah, I want to know, yeah.
Your dad was pretty clear that if he should get a lot sicker and need not to breathe on his own and sort of, he didn't want to be on machines. And he was like, if my heart stops, it's my time. I don't want to go through that CPR stuff.
He said that, and he...
Yeah, in fact, we filled out a form that he signed being really clear that...
I'm sorry,
Well, it's hard to hear all this.
It's hard to hear, and I'm frustrated because, I mean, I want my dad around, but I know he hates hospitals, and I'm sorry, it's just, I don't really know how to process
it's a shock,
this. Yeah.
Right?
Yeah. Yeah.
Given he said that, I think that what we ought to do is follow his wishes and not put him on machines. I think that he's so sick and so short of breath, he may not make it over the next hours to days.
That soon?
I'm worried he's really not breathing well on us.
Okay.
Typically what we do when someone is so sick is that we give them medicine so that they're a little more comfortable. It's a medicine like morphine.
Mm-hmm.
And we sort of watch his body and see what his body's going to decide. Mm-hmm. We'll continue the antibiotics because sometimes I'm surprised. Mm-hmm. And yet I think if there are other people who need to come in and say their goodbyes, you probably ought to make some phone calls.
Okay. I need to call my brother, yeah. Okay, thank you.
Note how the provider provides information about the patient's illness before discussing his goals, explored patient values from daughter's knowledge, asked permission to discuss his previous decision, attended to daughter's emotions as information was given, and guided family with recommendation of plan of care based on patient's previous decision. In summary, during the second conversation, remember to start with the previous discussion and build upon it, ask open-ended questions, and deliver information in a sensitive, straightforward manner, avoiding technical language or euphemisms.